to meet your expectations. Today, we have a presentation from Dr. Carole Mitnick. Second-line medications for MDR-TB treatment, new drugs in the pipeline. Today, we will learn what second-line anti-TB drugs are used in MDR-TB treatment, with the emphasis on new TB drugs in development. It gives me great pleasure to introduce you to Dr. Mitnick. Dr. Carole Mitnick is an assistant professor in global health and social medicine at Harvard Medical School. She is an associate epidemiologist in the Division of Global Health Equity at Brigham and Women's Hospital and senior research fellow at Partners in Health. She has 15 years of experience in programmatic support, research, policy, and advocacy related to increased access to high-quality, appropriate treatment for TB, and especially MDR-TB. Dr. Mitnick's particular areas of expertise and interest are epidemiology, clinical outcomes research, and operational research. Carole has worked extensively in Peru, and as a consultant to the Green Light Committee of the WHO, she is contributing to scale-up of MDR-TB treatment throughout the world. Okay, so now I would like to give a floor to Carole.
So thank you, Alex and for this opportunity. Good morning, good afternoon, and good evening to all of you who are joining from places far and near and hours convenient and not so convenient. Thank you really for this great opportunity to address you all. I'm going to disconnect the video component now, as Alex noted, to avoid difficulties. All right. So today I'm going to talk about the hopes and the development process behind moving from this scenario of daily or even twice daily regimes of many toxic drugs to a scenario in which this is what TB and drug-resistant TB treatment would look like. The cartoon pharmacist here is saying, they must work. I've never had a repeat customer. And this is a dream, I think, of treatment for TB and drug-resistant TB that could last only 7 to 10 days. I'm going to ask you some questions throughout the talk. If you've participated in previous webinars, they have mostly been multiple choice questions. In this case, they're going to be more open-ended questions, and I'm perfectly happy for you to share your thoughts and your responses in the chat box. So the first question at this point would be, what is your target for a new TB treatment? In considering duration, dosing frequency, composition, and populations, what do you think would be an ideal TB treatment? So, although we're nowhere near the 1-week regimen of which I dream, and maybe others dream of something even more ambitious, there is reason for some optimism about improvements. We've had no new TB drugs for 50 years, but the structures are improving to support new TB drug development. And that includes some new involvement, or relatively new involvement, of large and mid-sized pharma industry, as well as small biotech companies. There are many new compounds and drugs in the development pipeline. There are even completely new classes with new targets and new mechanisms of action. We actually have, and I'll discuss this in some detail, 2 new drugs in later stage clinical development whose registration is expected in the next year to 18 months. And then there are existing classes that are being optimized for the treatment of tuberculosis. And there's been a new effort to try to involve the regulatory agencies, which have been perceived as one of the obstacles to involve them in simplifying the development of new treatments. Just to give you a feel for what is in preclinical development. Most of the talk is going to be on drugs in clinical development, but I just want to give you this idea. This comes from the website of the Stop TB Partnerships Working Group on New Drug Development, and you can see that there are 6 drugs in preclinical development and combination testing. At this stage, developers are looking at animal studies that might predict likely human safety and efficacy. They consider production at this stage, what it takes, can it actually be scaled up to be used, and they evaluate toxicology and pharmacology, and they look at the absorption in animal models and the distribution, metabolism, excretion. You'll see that 2 of these are in red. 2 of these are in red. Those are the 2 that are entirely new classes of drugs. The others are drugs that are derivatives of existing drugs or members of classes that are already in late-stage development. As I said, that's sort of the end of my discussion of the drugs in preclinical development, but this shows you the whole drug pipeline. It's also from the site of the Working Group on New TB Drugs, and you can go to their website at www.newtbdrugs.org at any time to get an update on the pipeline. So you can see then from this chart that there's 1 drug in phase 1 clinical development, 6 drugs in phase 2 clinical development, and 4 in phase 3 clinical development. And we'll talk most about the most advanced of these, and I'll talk to you a little bit about the stages as well in just a moment. I also just want to present a little bit of context for concern about success of those that are actually in preclinical development. So looking at the success of drugs for all sorts of indications, only 1 compound in preclinical development out of 20 in preclinical development is estimated to ever make it to registration. Specific to TB drug development, there was a model done that estimated that the probability of introducing at least 1 anti-TB drug by 2010 was estimated at less than 5%, turned out to be true, and a new regimen by 2015 being less than 1%. And this relates in large part to lack of financial motivation by the pharmaceutical industry to get involved, given that TB largely affects poor patients and is largely supported TB treatment is largely supported by the public sector, and there has been a lack of public sector involvement in research and support of research to fill this gap. This has led to a routine shortfall in resources available for TB drugs. That shortfall is estimated by the Treatment Action Group to be on the order of $1.5 billion each year for TB research and development. That does not include the shortfall for TB treatment. That's just for research. And you can see from this slide that TB, by comparison to HIV, is much less well-funded TB research, and then if you compare it to chronic non-communicable diseases, obviously the gap is even greater. So before we actually talk about the drugs, I just want to make sure that everybody's on the same page about the terminology for the different kinds of trials. So roughly speaking, the earlier phase trials, so the phase 1 and phase 2 trials and the PK/PD studies, generally are shorter. You can see they're on a scale of days to weeks. They're smaller, so 10s, 20s of patients, and they're really generally focused on healthy subjects. They're not TB patients. Entering the phase 2 trials is where you start to include TB patients and usually begin to look at efficacy, also still considering safety. These early bactericidal studies, early bactericidal activity studies, my apologies, are typically still very small, about 10, 20 patients per arm, and they're usually only done over 1 or 2 weeks. These are the first efforts normally to understand the activity of a new drug in humans. The problem is that many drugs, pyrazinamide being kind of the prime example, do not have good early bactericidal activity and therefore don't appear to be active in this kind of study. This is especially a concern. You'll note that EBA studies are normally done with one drug, but when they are attempted in drug combinations, especially with isoniazid, which has extremely strong early bactericidal activity, the effect again is often very difficult to discern. These phase 2b studies are larger and longer. They still tend to continue to look at efficacy and safety, and with a short like 2-month endpoint, and then in the latter phases, these are much longer in phase 3 and phase 4 studies where we have to look at more rare events. They're much larger and harder and more expensive to run. So this raises the next question, which is, what does an EBA, or early bactericidal activity study, measure? Now we'll move on to the new drugs. I think we'll talk about what I would consider the most exciting and most advanced developments first. There are 3 drugs in this category: PA824, Delamanid, which is its trade name and is also known as OPC 67683. Bedaquiline, which is also known as TMC 207 or J. I will try to use the trade names for these last 2 drugs, but if I fail to, I just wanted to give you the other names. So PA824 is a nitroimidazole. It's one of 2 of that class that we'll discuss today. It's being developed by the Global Alliance for TB Drug Development, and its mechanism of action inhibits cell wall biosynthesis, and it's been shown to have in vitro activity against both drug-sensitive and drug-resistant TB. The PA824 was submitted to a 14-day dose-ranging EBA study and found that all of the arms tested were safe and efficacious. The next step was to look at a multi-drug study, a multi-drug EBA study, in which the investigators included PA824, this novel nitroimidazole, pyrazinamide, and with or without moxifloxacin. There were multiple arms explored. And the investigators concluded after that study that the PA824 pyrazinamide moxifloxacin regimen was the best, and they're moving that into an 8-week phase 2 open label study that they're calling NC002. They are interestingly including in this trial drug-susceptible patients who will be randomized to either the experimental arm or to the standard isoniazid rifampin ethambutol pyrazinamide arm. And then they are also including a separate arm of drug-resistant patients who will only receive the experimental arm. The objective of this study is to shorten treatment, reduce cost, and offer a regimen that is compatible with antiretrovirals. The TB Alliance, as I mentioned, developing this compound, has had high hopes for having a single regimen that would be useful for all TB patients, HIV infected, not HIV infected, MDR, drug susceptible. I think their enthusiasm or optimism has been tempered by getting a better appreciation for how much pyrazinamide resistance there is among MDR-TB patients, and so they are considering some other options as well. The TB Alliance also has another study that they're planning, this NC003, which would be a regimen containing bedaquiline, which I'll talk about momentarily, PA824, pyrazinamide, moxifloxacin, and clofazimine. They're also exploring the possibility of a more aggressive rescue or salvage regimen that could be studied in a non-trial setup, but in settings where aggressive screening and follow-up are possible, and that it would probably be tested in XDR patients and likely not start until at least 2013. Oh, sorry. I'm not sure what's happened here. The next drug I will talk about is Bedaquiline, or TMC-207, which is from another novel class. It's the Fluoroquinolones, which act on Mycobacterium tuberculosis by inhibiting ATP synthase. This drug has been developed by Johnson & Johnson affiliate Janssen Pharmaceuticals. It is metabolized by CYP3A4, so co-administration of rifampin with TMC-207 reduced TMC-207 levels by 50%. Consequently, the company decided to explore TMC-207 in MDR patients. They carried out some preclinical work and early clinical work, and subsequently carried out a phase 2 study comparing bedaquiline with in a background regimen to placebo in the same background regimen. It was a two-part study, and this first part exhibited by the chart on the left. They enrolled 50 patients just for 8 weeks, and then in the second part they enrolled an additional 150 patients. The outcomes from both studies were very encouraging, showing a much accelerated time to conversion in the TMC arm, both when just looking at outcomes after 56 days and also looking at outcomes after 24 weeks. The comparison arm had about 9% culture conversion in midget, while the intervention arm containing bedaquiline had a greater than 40% conversion. That 9% is admittedly very low in the placebo arm, and it is possible that that is due to the relatively poor background regimen used in South Africa, which affected conversion in such a small proportion of those in the placebo arm. With respect to adverse events with bedaquiline, there were not major differences in the two groups. The exceptions were in nausea, which seemed to be more common in the bedaquiline group, and then also there was an episode of grade 4 very serious hyperuricemia in the bedaquiline group. Another concern is cardiotoxicity for this new drug, and the authors found no consistent or clinically relevant changes in EKG during the 8 weeks. There were increases in QTc interval in both groups, more pronounced increase in bedaquiline, but no cardiotoxicity. The exciting news is that last month the company submitted their dossier to the U.S. Food and Drug Administration for conditional approval of the drug. It is also available through compassionate use for patients who meet a specified set of inclusion criteria. Generally speaking, it's patients who are either pre-XDR or XDR patients. It's important to note that this compassionate use structure is a very individual thing. Individual doctors have to request permission to treat patients and request access to the drug, and each patient who would be treated under compassionate, and there has to be a regulatory structure that permits compassionate use in a particular country. So this brings me to question 4, whether compassionate use is an individual or a programmatic approach to gain access to a new compound. Moving on with Bedaquiline, the next step is a phase 3 superiority trial. They are looking at a fairly novel approach. They are testing the superiority of a bedaquiline-containing regimen that also contains kanamycin, clofazimine, high-dose levofloxacin, prothionamide, high-dose isoniazid, versus a placebo-containing regimen with the same companion drugs. This is essentially the regimen that has been piloted in Bangladesh, and I'll talk more about that in a minute. They are looking at a 6-month intensive phase with the possibility of stopping the injectable sooner if there is a good response, and a continuation phase that would only go for 3 months, so for a total of 9 months. They will enroll and randomize 600 patients in a 1-to-1 ratio to the placebo and bedaquiline arms, and the primary endpoint is relapse at 15 months, but they will follow patients until 21 months. They will include patients who have HIV disease and are on ART. They will not be including children. The next exciting development is the drug known as Delamanid, or OPC. This process is being shepherded by the private Japanese pharmaceutical company Otsuka. And although their efforts really started after those for bedaquiline, they're a little bit ahead of the development efforts for bedaquiline as well. You see similar phase 2 results where there were 2 different doses tested in phase 2 of Delamanid, 100 milligram and 200 milligram dose, and you see that conversion occurred more quickly in the Delamanid arms than in the placebo arm. The difference was not quite as great because the conversion rate in the placebo arm was much higher than in the placebo arm in the bedaquiline study. The big concern with with Delamanid is the cardiac risk. And in this slide, you can see that there was there was QT prolongation in the Delamanid arms, 16 and 21 milliseconds compared to 6 in the placebo arm. But like with the bedaquiline, there were no cardiac events. Their next step is also a phase 3 trial. This is actually already underway. Their objective is to evaluate the safety and efficacy of Delamanid administered orally as 200 milligrams total daily dose for 6 months in patients with pulmonary sputum culture positive MDR-TB. And it's Delamanid with an optimized background regimen versus placebo with an optimized background regimen. Here the investigators are using the standard WHO recommended optimized background regimen. Sorry, let me be clear. It's not a standardized regimen, but they are using the WHO recommendations to formulate the optimized background regimen rather than using the shortened regimen that the bedaquiline study is using. Similarly, it's including HIV patients, but not pediatric patients. Also similarly, the company has filed for registration with the European Medicines Authority earlier this year and are hoping for conditional approval of the drug this year or next. And they too are working on a plan for access through compassionate use. Another new drug, not quite as far advanced, is called SQ109, and it's being developed by a small biotech firm known as Sequela. SQ109 is an analog of ethambutol, and it's been shown to have early activity against ethambutol-resistant Mycobacterium tuberculosis, and also being explored for use against H. pylori The phase 1 studies have been completed, and there were some problems with absorption. They also had difficulty demonstrating early bactericidal activity in a combination regimen, which included isoniazid. And remember, I mentioned that that is a problem with including isoniazid because it itself has very high early bactericidal activity. They're now moving forward into longer phase 2 studies with moxifloxacin and high doses of rifampin. Another class I'll talk about are the oxazolidinones. They work against MTB by inhibiting protein biosynthesis. Linezolid is probably the best known of this class. It is a registered drug, but not for TB. It has been used off-label considerably with well-demonstrated neurologic, ophthalmologic, and hematologic toxicities. There's been little ability to demonstrate the activity in kind of conventional designs in either mouse data or in EBA studies. And it was subjected to a randomized controlled trial in South Africa, the results of which have not yet been published, but my understanding is they were somewhat inconclusive. Nevertheless, there are many, many case series that show promising activity, including in XDR patients in Korea and other places. There are 2 attempts to optimize this class of drugs, one by the company Pfizer, and it's a drug known as PNU, or Sutazolid is the trade name. Sutazolid has completed phase 1 studies, and in those demonstrated both improved activity and safety over linezolid, and they're now moving into phase 2 studies. The other member of this class that's being optimized is work being carried out by AstraZeneca called Posizolid, I think is how it's pronounced. And early studies again demonstrate activity in mice and decent tolerability at multiple doses in humans. The next step is a phase 2 study in South Africa, and it's likely to start soon. Moving now into drugs that arguably could not be considered new drugs. We'll talk about the fluoroquinolones. This slide is actually a little bit more relevant for drug-susceptible TB as it compares the ability of moxifloxacin to the standard regimen to eliminate bugs in the mouse model, but I'm gonna use this just to give you the background of why Moxi was considered useful for treatment shortening both for drug-resistant and drug-susceptible TB. So first, let me just orient you a little bit on the slide. This y-axis represents the log colony forming units in mouse lungs, so basically the bacillary load in mouse lungs. The x-axis is the duration of treatment in months. The top arm, the top line here, is the decline in colony-forming units in an untreated control arm. And this line, which is a little bit hard to see, I'm sorry, is the standard HRZE regimen. And what these investigators found is that by replacing ethambutol with moxifloxacin, so looking at this yellow label on this bottom arm, they were able to completely sterilize the mouse lungs in 3 months compared to 6 months with the standard treatment. And this is what led to potential interest in the potential of moxifloxacin to shorten both drug-susceptible and drug-resistant treatment. I'm going to start with a discussion of their potential in drug-resistant patients, and if we have time, we can talk about drug-susceptible as well. So, one of the early efforts to look at shortening drug-resistant TB treatment with the use of a high-dose fluoroquinolone was explored in Bangladesh and reported in a paper in 2010, the investigators introduced a series of changes in their standard MDR-TB treatment over a period of about 6 years. They changed drugs, they changed duration, and they changed dosing. It was not really a systematic analysis because sometimes they changed more than one thing at the same time. But their experiment ended with a 9-month regimen containing 4 months of kanamycin, clofazimine, gadifloxacin, ethambutol, isoniazid, and pyrazinamide, followed by a 5-month continuation phase containing gadifloxacin, ethambutol, pyrazinamide, and clofazimine. The gadifloxacin and isoniazid were used at higher than standard doses, and this was conducted in a population that had never received second-line drugs. They were extensively treated with first-line drugs, 90% having received a Category 2 regimen, and you can see that there was extensive lung damage in the population. The results were very encouraging, relapse-free cure in over 85% of the patients enrolled. This spawned the introduction of a similar regimen in 3 Central West African countries with some variability in the composition and dosing. For example, in some sites they're using moxifloxacin, in some sites they're using gadifloxacin. They varied the duration of the thiamide, and not all are using clofazimine. The preliminary results are encouraging, but I note that in these sites, the regimen has only been explored in patients without prior second-line exposure, and there's been limited follow-up. So this raises my next question, which is, in what population has the so-called Bangladesh regimen been demonstrated to be effective? And what are the implications of its effectiveness in a limited population? I hope we'll have time to talk about that question towards the end. So the next step in evaluating the high-dose quinolones is a formal randomized controlled trial known as the STREAM study, and it is going to randomize 400 patients in a 2-to-1 ratio to the study regimen or to the local standardized GLC regimen, the 24-month regimen, and all patients will be followed up to 27 months post-randomization. This is the study regimen, and just noting some highlights that after 3 months, the daily kanamycin will become 3 times a week. The intensive phase can be extended to 6 months from 4 months in those who don't respond. And note also that doses of Moxi go up to 800 milligrams in the greater than 50 kilogram group. The study is hoping to address effectiveness as well as safety and cost issues. Now I'll address briefly the possibilities of fluoroquinolones for shortening short course treatment. Remember, I showed you the mouse data that illustrated the superiority in the speed of killing in the mouse a Moxi rifampin pyrazinamide regimen, and that subsequently led to 3 trials of short course treatment, 2 where Moxi replaced ethambutol and 1 where Moxi replaced isoniazid. This first study was done by the Tuberculosis Trials Consortium of the CDC, and found that although Moxi was more active than ethambutol early, there was no difference at the 2-month endpoint, which was the pre-specified endpoint. The second study to explore this same question did find a difference at 2 months between the ethambutol and Moxi containing arms, where 80% had converted in the Moxi arm and only 63% in the ethambutol arm. The third study used Moxi to replace INH and also found no difference at 2 months. The apparent difference that you see here is actually the difference between liquid media and solid media, not between the two arms. So while all the studies found the combination to be safe and tolerable, these studies may have raised more questions than answers about how predictive mouse models are for duration, and also whether 2-month sputum culture conversion is an adequate surrogate marker for treatment shortening. There is now a phase 3 study going on to try to answer this question. Actually, 2 phase 3 studies looking at this question. This Remox TB trial had 3 arms in it: a standard 6-month control arm, a 4-month arm in which moxi was substituted for ethambutol, and a 4-month arm in which moxi was substituted for isoniazid, and asks the question of whether these 4-month regimens are not inferior to the 6-month standard control. The study has completed enrollment, and results are expected in late 2013. Simultaneously, there was an exploration of gadifloxacin as a replacement for ethambutol. In this phase 2 trial, there were 4 arms. There was the control arm. There was an arm with HRZO, O being ofloxacin, an arm with isoniazid, rifampin, pyrazinamide, and gadifloxacin, and an arm with isoniazid, rifampin, pyrazinamide, and moxifloxacin. And the authors found that there was a much more rapid decrease in the bugs in the Gadi and Moxi containing arms, and that was distinct from the ofloxacin and ethambutol containing arms. A phase 3 trial was conducted. It has been over for quite some time, and results are still pending. My understanding is that there's been a problem with analysis. Obviously, the results are also of some a questionable value at this point, given the withdrawal of gadifloxacin from the global market. I would pose one more question, which is whether late generation fluoroquinolones should be reserved for drug-resistant treatment or used in drug-susceptible treatment. So I have a few more slides. So these are some of the other fluoroquinolone trials that are going on, both exploring drug-susceptible and drug-resistant TB. And then I have some slides on the use of or testing the rifamycins, particularly rifampin and rifapentine, at higher doses for the possibility of shortening short course treatment. I think I'm going to leave those for now and try to leave some time for questions since we don't have too much time left. I'm happy also to address questions later by email about the rifamycins if that is of interest. So let me just skip to my sort of conclusion slides. So just note that there are a few other hopeful developments that I haven't really addressed in any depth. There is interest in exploring thuridazine for anti-TB activity. It works through efflux pump inhibition, and recent mouse work showing modest activity at the doses used for psychiatric treatment. Other efflux pump inhibitors are also being explored as sort of adjunct treatment for anti-tuberculosis drugs. And then there are some other developments more in the kind of infrastructure around TB drug development. So there's a lot of effort to build TB clinical trial capacity, including MDR. I noticed that one of the questions that came up was how how sites are selected for trials, and honestly it's a matter of looking at the burden of disease and if it's high enough to enroll patients quickly, and the ability to adhere to a very limited clinical protocol, and also the quality of laboratory. That labs have really been proven to be one of the biggest challenges in getting the good results from clinical trials. There's a group that was established about 4 years ago called Resist TB, which is really trying to advocate for additional resources for trials to optimize drug-resistant tuberculosis regimens. I've talked a little bit about the compassionate use mechanism being used more for drug-resistant TB. There's also been increased collaboration with different clinical trials groups trying to build on existing infrastructure. And then lastly, there is an effort, a regulatory effort, or an effort of the kind of TB community to persuade regulators to consider an alternative to drug-by-drug approval leading to a new regimen, which they maintain could take 24 years by the time you get each of 4 new drugs, whereas their argument is if regulatory agencies would consider approving a full new regimen, that could be a shorter path to availability. So I think I'll leave the presentation at that and try to look at the questions. I'll click to expand questions, sorry. So what is the reason for low funding on research from the private sector? So my primary answer to that is just that tuberculosis is not a money-making disease for pharma. It is primarily a disease of the poor. Its treatment is primarily supported by governments, and governments tend not to either be able or willing to commit significant resources to these diseases for which they're not getting reimbursed for payment. So there's been very little incentive for pharma to engage in TB drug development. Yes, so the next question about whether early bactericidal activity equals the ability to kill Mycobacterium tuberculosis early on. It's very early on. It really focuses on the first 2 days. It is usually examined within 1 week. There has been a movement to examining EBA in over 2 weeks rather than just 1, but that's difficult to do in TB patients with only monotherapy, so the movement has been to combination therapy, but then it's much more difficult to assess the effect of a single drug. The next question, linezolid is still in clinical trials, so why is it already on the market? That's because it's been registered for other indications. It has never been registered for TB, and so its uses for TB are off-label. And I think initially there had been hope that one could accumulate sufficient data to warrant a label change, but I think given the toxicity, that seems unlikely. The next question is, let's see, hopefully we'll start with phase 3 of the Delamanid study here in the Philippines. Glad to be a part of it. That's fantastic news. We're also very glad that you're a part of it. Next question, which are the countries that are on the phase 3 trial of Delamanid? I do not have an exhaustive answer to that. I know that many of the countries that were involved in the phase 2 trial are being included, and a couple have been removed. So I believe that there are sites in the Philippines, in Peru, in Latvia, Estonia. I think they're going to try to include a site in India. I believe China is not being included, but I know there are also more countries. Oh, there were 2 patients on the phase 2 study in the US. I'm not sure they'll continue in the phase 3 study. And I'm sorry if that's not a completely complete answer. I discussed a little bit how the trial sites are already selected. Somebody notes correctly that gadifloxacin has been withdrawn from the market. What is the best regimen to date based on the recent literature? I could speculate, and I think that there is a lot of interest in moving forward with regimens that contain the two new drugs, Delamanid and Bedaquiline, as well as quinolone, clofazimine, and pyrazinamide, and or possibly linezolid and high-dose INH, but that is really kind of a composite opinion from a bunch of mouse data, a little human data, and I don't think we have the real answer to that yet. Yes, the very important point that primary quinolone resistance among some communities is reaching 40%, and I would add to that, and that prevalence is higher among those with MDR-TB. What will be the plan for them? This is something that we had, I think, been trying to convey to those who were trying to develop a single regimen for everyone that would include PA824, PZA, and MOXIE. And I think now there are plans to try to look at regimens that would be less dependent on quinolone. But nobody knows right now what the consequence of removing the quinolone from a regimen would be, because it's been such an integral part of the regimen, and I think everybody is really afraid to do that. It's an excellent and very important point for the future. If you use quinolones for frequently drug-susceptible TB, you are risking a possibility of resistance. So I think this kind of hits on the point that I was raising with my question. I think there are two very different schools of thought about whether one should be reserving quinolones for resistant TB, or whether one should be hitting an initial case of TB with the strongest regimen possible. And I would put myself on the former side. I would say that if the quinolone is only likely to shorten standard treatment by about 2 months, to take a regimen from 6 months to 4 months, I don't think that warrants the risk of increased resistance. If it could have a bigger impact on treatment shortening, I would conceivably revise my perspective. But at this point, it's an opinion. It is not. There's no science. And the next question is, if there is only one new drug getting registered and introduced in the market at a time, then isn't there a likelihood of resistance to it developing before the next one is approved? It's a very important point, and it just points to the need to be very, very careful about the introduction of these new drugs. I think that a reasonable rule of thumb would be that any new drug, in order for a new drug to be introduced into a regimen, it needs to be a regimen that contains at least 3 drugs that are able to protect against the development of resistance to that new drug, in order to avoid making one of these drugs useless very quickly. Oh, more questions, sorry. The next question, have these researchers come up with the best regimen to shorten TB? No, there is no best answer yet. There are several efforts underway, as I noted, several efforts with quinolones, and now also with higher doses of rifampin, and with this new drug SQ109, also with PA824, but no, we don't have an answer yet. Do you know safe treatment for a pregnant woman? So I am not a clinician, and I would defer that question to my clinical colleagues. I would recommend conversation on GHD Online, looking at WHO guidelines, which deal with special populations. Those could be helpful. Nothing for the pediatric population in the new drug development. So this is a very important point. The activist community, ourselves included, have really been working to pressure these companies to begin to think about pediatric populations and most importantly, a pediatric formulation very early in the process. The regulatory agencies are helping by requiring that the companies have a plan for exploring these new drugs in pediatric populations before they get approval, but they're still reluctant to do it. It's expensive, they feel like they're taking on a lot of risk, and so I think it's one of the things that we have to think creatively about is how we as practitioners and activists and researchers can facilitate the development of pediatric formulations and the testing of these new drugs in very important pediatric populations. So we have one more minute. So just a sort of slightly contrasting perspective about the use of fluoroquinolones in drug-susceptible patients, that they're already commercially available. Their use is not restricted often to TB programs, so because it's difficult to restrict, you might as well use them in drug-susceptible TB. Another question about kids. Generally speaking, after safety has been and efficacy has been demonstrated in adults, the next step is to just look at whether the dose response is the same in kids, but you don't need to demonstrate efficacy again, but you need safety data in adults before introducing it in kids. So I'm sensitive to the time, and I'm not sure if we have a couple of more minutes, Alex or Kiva, or if we need to end promptly at 10.
Hi, Carole. Yeah, we have a couple of minutes, yes.
Okay. Okay, so I'll go on. I'll continue with these questions. What's the best regimen for MDR-TB based on recent literature? I don't think there is convincing evidence to answer that question. I think many would consider the use of a late generation quinolone if there isn't demonstrated resistance to that late generation quinolone. Clofazimine is another possibility many are considering. Linezolid is another. If PAS and or cycloserine are available, those are also considered, but I don't think there is a best out there. If the other factors other than drug target are also not considered, new drugs may face also early drug resistance. So I think that this points to the need to be very careful about the way that drugs are introduced into new regimens, both in terms of combination drugs and also providing the appropriate support to patients to ensure treatment completion. Any new drugs with novel delivery mechanisms? This is an interesting question. I sort of glossed over the efforts that Ed Nardell, one of the previous speakers in this group, in this series, and others are involved in, which is to develop inhaled delivery of the aminoglycosides and polypeptides. This has been done with kanamycin for years, and now there are some new sort of molecules that seem to make penetration easier and more effective. These are in early clinical testing. That takes care of the next question as well, which I believe is the last one on my list.
Yeah, thank you very much, Carole. So today it brings our fourth webinar to an end. I would like to sincerely thank Dr. Mitnick for a very informative and interesting webinar, and I would also like to thank you all for your participation. I think you all agree that it was very enjoyable. We had a lot of questions, and I was trying to copy and paste questions to Carole, and I think all of questions relates to the talk was answered by Carole